When we talk UHC, it calls upon a very, very structured way that care can be rational. No system can provide unlimited care to everyone. And it cannot be that somebody that can afford can pay and get it, but somebody that is not able to cannot get it. It's a tricky one to answer, but I want to just get some thoughts on that. Saying, is rationing even necessary? Can it be done? Is there a well thought out way in which care can be rationed? And I will open it to any one of the four to try and take a shot at that.
Yes. Okay, sorry to steal the mic. Okay, rationing is, there's no question of is rationing necessary. Rationing is happening. It happens in the US, it happens in Canada, it happens in the UK. Even in places where they have great USA, rationing is happening. The way the rationing happens in those countries is they make you wait. And if they make you wait for 6 months to 1 year for a procedure, you might die in between. So they have rationed you out of the system. So rationing is, there is no question rationing is happening. How do we do rationing is the question we should ask, right? So now rationing cannot be left in the hands of the frontline doctor. Now he's going to say, oh, this person is from my community, so I'm going to give this person the treatment. That person is not from my community, I will sideline, right? This is what will happen. I mean, I'm not saying every doctor is like that, but these tendencies will come to the fore. The local politician will get treatment. The local, not politically savvy person will not get treatment. So we need an algorithm-driven rationing system, which is also centrally, where data can be gathered centrally, just like we have our organ transplants. In the country, we have an algorithm which determines who gets an organ transplant. So we need a similar thing for all expensive treatments, CAR-T treatment. We cannot afford CAR-T treatment for every Indian who gets liquid cancer. So we need to ration CAR-T treatment. We need to know. For example, I mean, we were talking earlier today about how do you determine whether Mr. X, who is 50 years old and has got 3 dependent children and a wife, versus Mrs. Y, who is 87 years old, who should get the definitive treatment? It's pretty straightforward. Mr. X should get it, Mrs. Y will die. And that is, we have to confront this reality that some people will be dying earlier than if they had been given treatment, because as a society we cannot afford to give the same treatment to everybody. Glioblastoma, people live for 3 months, 6 months. There are treatments that will extend it by 2 more months, but they're expensive. Do we want to extend somebody's life by 2 more months, whereas you can spend the same money vaccinating 1,000 children, right? So you might want to vaccinate 1,000 children and say, let this person die 2 months early. This is something, a reality of universal health coverage. We don't see it now because we don't have universal health coverage. But guaranteed, this will happen. In fact, this is a sign of a good universal health coverage system, that there is also a system of rationing healthcare, because resources are finite.
The other thing we should realize is the purpose of medicine is not to make someone immortal. We should accept death as a reality. More than death, it's the fear of dying and lack of social support. I'll give you an example. If there's a husband and wife, a sole wage earner who's a son, who has an accident, who's in the hospital. Husband and wife are 75, 80-year-old at home. The system doesn't care of societal supports or some social support to the family. You're talking, medicine by and large is a social science. This came up almost in 1800. A famous pathologist, Rudolf Virchow, called it as a social science and became a politician to try to reform, and miserably failed. But nevertheless, you need to have all these things plugged in. One of the things we completely ignore is what is the societal support at home when this person becomes ill. That's a sad reality now. You may have all the wealth, loneliness, children are at somewhere in the US or UK, persons cannot walk. There's no one to talk to. The society has become so kind of individualistic that you can't blame. The children are running around for their jobs, so on and so forth. There's a complete social disconnect. I think this has to be very, very, for people following a hip surgery or a traumatic surgery, the perceived sense of social support when the patient goes back is an important determinant how much physiotherapy is going to do and become well. So it's not theoretical. What I'm saying is not theoretical. It matters in terms of patient recovery.